Dr. Vinitha Mary Joy, Clinical Microbiologist, Antimicrobial Stewardship Committee and Infection Prevention and Control Committee Officer at KIMS ALSHIFA since 2 years. Completed MBBS and MD Microbiology from JIPMER Chandigarh. Fellowship in Infection Control and Clinical Microbiology from Tata Medical Center, Kolkata. Worked as a part of IPC and AMSP committee in various hospitals since 2019. Actively involved in molecular diagnostics and virology.
So, good afternoon, one and all. Thank you for that wonderful introduction. And thank you to KIMS ALSHIFA for giving me this opportunity. So, I want to talk about certain learning objectives. So, first I will just outline how we came to this point in infection control and then describe the various goals of IPC and as well as what it can enhance in a medical care center and also the challenges that we face. So what is infection prevention and control or IPC? So it is a discipline that is concerned with hospital acquired infections and it is similar to public health activities that you see outside, but it is practiced in a hospital and it focuses on using evidence-based practices to prevent the transmission of infection while taking care of patients. So why is it important in our current scenario? Because lots of data and literature from main international societies like CDC, ECDC and WHO have given rise to a very alarming data that hospital acquired infections have been rising over the past 2 decades, more than 36%. And in a hospital without an IPC committee, there is almost 20% increase in risk of infection. So since ancient times, man has always faced this obstacle of a tiny microorganism causing vast diseases and death. So we started with a lot of primitive means of infection control using multiple layers of clothes, trees, herbs, maybe even masks, and even a lot of religious rites to prevent infection. But the IPC as we know now started only in the early 1800s with some attempt at wound prophylaxis using cauteries, that is heating the wound to prevent rabies. And later, due to pioneers like Florence Nightingale who developed the sanitation and hygiene, Ignatius Semmelweis who started the hand washing principle that we know now, and Lister who developed the antiseptic surgeries. And finally, after Louis Pasteur described the germ theory of disease, we came to the start of the development of an infection prevention and control program. Later, we developed antibiotics against these germs, but it only took 20 years from the start of an antibiotic to lead us to multi-drug resistant, antibiotic resistant infection like Staph aureus infections in nurseries. So following that, the attention of the medical community turned to how to prevent it from coming up. So we started making surveillance, documenting the infections that are happening to see how we can stop the infection to happen. And later we developed methods to prevent outbreaks as well as the pandemics. So what are the goals of IPC? It is only to prevent the spread of infections from patient to patient, patient from healthcare, and also from healthcare providers to patients. And consequently, to prevent the patients from getting anything from the hospital as such, that is to prevent hospital acquired infections. So what are the functions of an IPC community? So basically, we have to obtain and manage the critical data and information regarding anything that causes infection in a hospital. So for this, we have to implement certain evidence-based practices, standards and guidelines through policies. We also have to intervene directly to prevent infections from spreading between patients, to provide an effective occupational health program for all staff in the hospital, and to train and educate the healthcare workers as well. we also have to provide communication to the staff and patients and bystanders regarding all that we have been doing to prevent the infections from coming, and we have to keep evaluating and improving the program in quality. So what are these policies and procedures? They are simply a guideline, a set of guidelines which are made by a group of people which form the Infection Control Committee. So they include a lot of procedures that you may have seen in your work. For example, even just cleaning a room, and then for disinfection of the OT equipment, sterilization of OT equipment, just waste management. Many things need to be written down and documented, which turns into being the policy. So who will make all these things? As I mentioned before, they are made by a committee of people who are collectively known as the Infection Prevention and Control Committee. So who should be involved in it? Always there should be somebody from the administrative side to provide legal and financial and legislative support to all the policies that we are framing. And the policies as such are framed by experts. So that would include a doctor who is well versed in infection control, an intensivist or a clinical physician, then a microbiologist as well as a pharmacologist. They are the minimum members required for an infection control committee. Other representatives are the infection control nurses, the pharmacists, lab personnel and statisticians. So coming to IPC practice today, it includes mainly 7 prongs. So we have first the surveillance. So what do we do in surveillance? We have to look out for and catch all the risks to infection control. So they include hospital acquired infections, invasive device uses, bloodborne pathogens like HIV, antimicrobial resistance and many others. So all aspects of infection control needs to be surveilled and monitored regularly. So in our hospital we have certain forms which we use for active surveillance, and passive surveillance data is collected from the ground up, and the data is presented monthly as well as annually in a cumulative form to analyze and report on the improvements required. Now we come to another aspect of surveillance, that is notifying the recommended government authorities. So that is mainly regarding any infectious disease which is communicable. So we have the NICSHI for TB, we have KESATS for HIV, all other communicable diseases to IDSP. So this duty also comes under IPC, and it is actually a government mandated job which has to be done on time and regularly. So this is where the data is uploaded in online to IDSP based on whether it is lab confirmed or a presumptive data. Any and all suspicious cases have to be informed in these things. Now we come to the second prong, which is the outbreak investigation. So we have already come through many outbreak investigations over the last few years, which includes SARS and Nipah, and this is also involved in in-house outbreaks. So that means if there is an outbreak of hospital acquired infection, or maybe a single strain of MDRO is causing an infection in a particular ward, so there are also outbreaks which need to be analyzed and managed as a in-house localized outbreak in the hospital. So it is essential that there is a reaction plan and a response team to be prepared for any and all types. So this is how an outbreak case is reported to the authorities, and also have a policy regarding the ongoing and existing outbreaks in our hospital policy. Now we come to the mainstay of IPC, which I am sure everybody knows. This is the prevention of spread. So it includes standard precautions as well as specific transmission based precautions. So this is all to inhibit or stop the chain of infection. So all these policies have to be documented and also published all over the hospital. So not only the staff and the patient knows, all visitors and bystanders are also aware of these things. And for the staff, the auditing of the compliance to these policies also must be done actively as well as passively. So this is an audit form for hand hygiene that we are using in our hospital. It can be performed as required from each hospital. So these are the charts and work instructions which should be pasted on public thoroughfare areas, transmission-based precautions should be placed near specific areas where these kind of infections are isolated. For example, airborne precautions for tuberculosis, etc. So, along with all these precautions, we also have to monitor housekeeping and cleanliness, because that is also a part of prevention of infection spread. So, there should be a audit and checklist tool for housekeeping as well in our IPC policy. Now we come to the antimicrobial surveillance. So, what should be done? We have to at least know the basic data in the hospital before forming a policy. That is, which is the most resistant strain that is commonly found, which is the most at-risk area in our hospital, and which are the high-risk settings in our hospital, whether transplant patients or malignancy patients, etc. So, our policy needs to be focused on these areas. So, how can we find out these answers? So, basically we have audit forms for basically we have already protocols for specific AMR cases. For example, in case of MRSA, the decolonization as well as the isolation protocol required has already been made. So, these should be well known to staff as well as the patient involved. Now, how do we know the baseline data? So, that we get from the microbiology lab as well as the microbiology analysis, and based on that, the infection control preventionist or the microbiologist will form the policy. So, these are the basis of monitoring and surveilling the antimicrobial resistance and antibiotic use. So, that actually helps us to go into the second branch of IPC, which is antimicrobial stewardship program. But currently it is also its own individual setup which is required for all hospitals. But on its own, we have a lot more work to be done in AMSP. So in our hospital, for policy protocol monitoring, we are looking at rational use of antibiotics as well as restricted use of antibiotics using a pre-authorization form in order to make sure that there is minimal overuse of antibiotics. Now we come to occupational health. So occupational health is a very big issue in hospitals because we are at the highest risk of getting many bloodborne and other communicable diseases. So as an administrator and an IPC officer, we should be involved and available to check all employees, or there should be a pre-employment checkup as well as annual checkups for those who are in high-risk areas, and this includes food and beverage corporation employees, following which all staff which are at high risk should be vaccinated and their vaccination record should also be kept as a proof. And following other occupational hazards like blood or body fluid spillage, there should be a protocol which should mention what is to be done at an event or a needle stick injury, following which any post-exposure prophylaxis should be given. So these are the forms that we are following in our hospital for needle stick injury, following which the person is educated regarding any negligence if it has happened, also whether there should be any change in our protocol following analysis. Now finally, we come to education. So forming all these policies and protocols is not enough. It has to be disseminated and reinforced to all staff. So how can we do that? First, there should be an orientation every 3 months for all new staff regarding existing policies. There should be hands-on training for staff regarding their specific fields of expertise, and there should be an annual update. So these updates should be based on any new guidelines that are coming up internationally or nationally. Along with that, we are also authorized, or we are responsible for educating the public regarding infection prevention control methods they should follow. So we should always be involved in community-based activities as well. So as a part of this education program, there should be a training calendar that any IPC committee should form, so that there is a regular update on all staff regarding existing policies. There is no way there is a lacunae where one particular staff or one group of staff are missed on learning certain policy matters. Now we come to the final part of an IPC program, that is audit. And this comes to the most important aspect, because only through auditing and continuously improving that we can maintain and improve our IPC quality. So basically it includes reporting of NCs or any issue of concern for infection prevention and control, and we have to identify where changes or improvements are needed. So monitoring and evaluating the effectiveness of the existing policies and also the risk management protocol. Many audit tools are available. The one we are following is the WHO assessment tool, and based on that the changes and improvements are updated annually. So what are the basic elements of an audit? So basically we try to audit adherence to the policy in infection control as well as antibiotic policies. We look at the risk assessment plan and whether it is being implemented and checked annually. Look at the biomedical waste management protocol and whether it is followed properly. And all alert outliers noticed via surveillance, that is in hospital acquired infections, MDROs, etc., should be notified and assessed, analyzed accordingly based on existing benchmarks, following which there should be a root cause analysis as well as a corrective action and preventive action for continuous policy improvement. So I just want to explain the term called benchmarking, which is very unique to IPC as well as quality improvement. So basically it includes a public report that apply a standard methodology to estimate the risk adjusted hospital acquired infections and or their preventive processes across a large network of healthcare facilities. So basically it gives us existing baseline data to compare our surveillance data to, because just knowing that we have 10 cases of VAP is not enough. We have to compare ourselves to similar hospitals or similar demographic patient care areas so that we can continuously improve. So the internal benchmarking includes basically comparing between ICUs or between wards, but external benchmarking includes comparing with national and international guidelines like NFHN or ECDC or WHO for improving the patient safety and improving the prevention strategies. So basically this is the benchmark that we are following in our ALSHIFA. We also compare with other KIMS hospitals in order to check our current standards. So what are the challenges that we face in IPC? Basically it is that we have now increasing reporting requirements and very little manpower. Manpower is always the main issue, and we also have a major issue that compliance is very minimal to hand hygiene, especially when the doctors are visiting consultants and also when there are rotating staff like physiotherapists or X-ray technicians who may not always be aware of the current protocol. And then there are emerging multi-drug resistant pathogens like C. difficile and H1N1 influenza and Candida auris. And there are certain financial aspects as well, where increased HAI being publicly demonstrated leads to certain increased scrutiny to hospitals, especially when it is a small hospital under a bigger conglomerate, because there will be comparisons with other hospitals. And in certain outside India countries, sometimes insurance and reimbursement is also influenced when the high rate is high in a hospital. So these are the challenges that most IPCs face. And majority of them cannot be improved based just by ourselves. It has to be a cooperative effort. But how can we just improve our efficacy? So basically it is only by collaborating with different groups of staff. So the preventionists, IPCs, should be collaborating with the link nurses and staff nurses to get the data from the wards directly regarding HAIs and MDROs, and regarding pharmacy teams for antibiotic surveillance, regarding housekeeping teams for the environmental cleaning and surveillance data, and also using automated LIS techniques so that the data is automatically back-ended from the IT system. So if we have these kind of support from the hospital and the other staff, the IP's work is much easier. So coming to the conclusion for IPC challenges, so the most important thing will always be breaking the chain of infection, and the most important aspect of that will always be hand hygiene. So these are the resources that I have used for my presentation, and thank you. I hope that I am able to make you understand some parts of the infection prevention control in ALSHIFA.